excuse me, and we'll go ahead and get going. So just to go over basic presentations, when you're going through your EDX and you're taking a look at nerve conduction data and you're trying to figure out, well, what is this problem? The terms conduction block mean something to you, yes?
Yes.
What is a conduction block?
An area that is reduced, well, velocity for sure, maybe reduced amplitude.
Okay. A reduced amplitude where and with respect to what? Because what does reduced amplitude typically mean?
It generally means axonal loss.
Okay, so what's a conduction block?
Conduction block is basically, I believe, where the myelin is reduced to the point to where it comes in on the axons, I think, and starts reducing the axonal input. But I'm probably wrong.
Well, it's okay. Anybody else? What's conduction block mean? Bill?
Complete axonal disconnection.
A lack of impulse?
Yeah, a lack of impulse, but where? How would you identify a conduction block?
Over a limited portion of the nerve.
Okay. So a conduction block is a primary demyelinating issue where electricity fails to continue to propagate past a lesion. But distal to the lesion, when you stimulate that nerve, there's a reasonable response.
Yes.
Okay, so conduction block is a drop in amplitude from a distal stimulus when you go above that site. So a proximal stimulus shows a reduction in amplitude as compared to the distal segment.
Yes.
Doesn't necessarily have to show slowing, although most of the time you'll often see slowing with conduction block or partial conduction block. So in order for us to identify what is or isn't conduction block, we have to be able to stimulate across the lesion. That is, we have to stimulate distal and we have to stimulate proximal too, wherever the problem is.
Or
I'm
like
sorry?
I'm thinking of the elbow, like comparatively, you mean?
Mm-hmm. Mm-hmm.
Mm-hmm. Yeah.
So in a partial or a complete conduction block across the elbow, below the elbow, you might see a reasonable CMAP, and everybody knows that CMAP is compound motor action potential.
Right.
But proximal to the elbow, we see a drop in amplitude. And we typically say that anything that drops in amplitude 20% or more over a short segment is partial conduction block. Okay? So what's necessary to ID conduction block? You have to stem distal and proximal to the lesion. Otherwise, you may not be, you won't be able to tell that there is or isn't conduction block. Does that make sense?
Yes.
We're talking about sensory, correct?
I'm talking about, typically conduction block is referenced in terms of motor function, but a lot of people, me included, will talk about conduction block from a sensory perspective as well. For instance, if we did a median sensory study in the palm and we saw a nice response and we went to the wrist and it went away, that's a sensory conduction block at the wrist. And you'll see that in patients with carpal tunnel. But you can't apply the 20% rule in a sensory nerve, and we can talk about that at another time. What about axon loss? How does axon loss present in nerve conduction?
Reduced, well, definitely reduced amplitude.
Okay, where? How would you know in a nerve that that it's axon loss and not conduction block?
Axon loss would also be present distal to the injury. If there was no axonal loss, it would be intact distal to the injury.
Excellent. That's right.
Okay.
So important to understand where our lesions are when determining whether something is conduction block or axon loss. Good. So if there's motor axonopathy, so say again at the elbow, if we see a reduced CMAP from wrist to APB, then we suspect that there's possibly axon loss.
Yes.
Because the amplitude, and then we go and we shock below the elbow, it's still low. We go across the elbow and it's still low and slow. We see demyelination at the elbow, but we've got low distal CMAP amplitude. So we think that there's the potential for axon loss distally. And based on what we talked about last week, what's important to do to confirm the presence or absence of motor axonopathy?
EMG.
Do an EMG. That's right.
Mm-hmm.
Good. Okay. So before we begin and talk about other types of things, let's look at basic review of nerve lesions. So this is normal. Okay. Here we have the potential to the right side. And let me see if I can pull up my drawings here. So this potential represents a superficial peroneal sensory response where we stem at the lateral lower leg and we're recording the superficial peroneal response off of the foot. Okay. Pay no attention to the exact locations because we know that we're probably going to record this thing right in here, aren't we? With a reference electrode right in there. But at any rate, this represents the superficial peroneal sensory nerve. This response represents a motor nerve conduction study from below the fibular head recording from the tibialis anterior. And this response represents stimulation across the fibular head and recording from the tibialis anterior. Everybody buy that? And
Mm-hmm.
you can orient to what this shows, okay? So this is a normal, and if we have to come back to see what normal is, we can. But this is a normal motor and sensory nerve conduction study of both the peroneal motor to the tibialis anterior and a superficial peroneal sensory response. Okay, we good?
I know. I feel like, are you jumping around sensory to motor, or you're all sensory right now?
What is this?
The tibialis anterior. You're not saying tibial nerve. You're saying
This is the superficial peroneal sensory nerve. This is the peroneal motor nerve recording from the tibialis anterior. This one references what happens when we stim below fibular head. This one represents what happens when we stimulate above fibular head.
okay, motor. Mm-hmm.
This is motor.
Yep.
This is
That's
sensory.
sensory. Got it.
Okay. So now you guys tell me what kind. So now I'm looking for how you were to describe the lesion. All right. We're going to move to the next slide. Ooh, and I start out with a hard one. What might present like this? What kind of problem would present like this? First of all, is this a normal superficial peroneal sensory or abnormal based on what we saw on the slide before?
Normal.
Okay.
Yeah.
What about the below fibular head CMAP? Is that normal or is that abnormal?
I would say abnormal.
It's low, isn't it? And when we go above the fibular head, what is it?
Abnormal.
Okay. Now, what types of conditions might we see this presentation? Not what types, but what type of condition might we see this very condition?
Radiculopathy.
Good. Why?
Well, I'm confusing basically you're above and below where you'd expect the entrapment to be, and it's the same. So the problem is further north or proximal.
Very good. So we don't know a lot about conduction block. We know that there's not conduction block at the fibular head, is there?
Right.
Right. And the superficial peroneal sensory response is intact. Why?
Well, that's confusing to me because I'm not tracking on.
Preganglionic.
Okay.
I'm sorry, it's postganglionic.
No, say it again.
Well, the
Preganglionic?
superficial peroneal is postganglionic, so if there's a radiculopathy at L5, the motor nerves could be affected, but the sensory, because its dorsal root ganglion is distal, would be a postganglionic, and that the postganglion is intact because it's because the issue is preganglionic. Sorry,
There you go. There you go. Yeah, but you walked your way right through it, so that's perfect, and that's exactly right. So the injury in a most nerve root lesions occur proximal to the dorsal root ganglia, which means the cell body of the sensory afferents are intact. So even though this patient may have numbness and tingling in the L5 or superficial peroneal distribution, there's preservation of the superficial peroneal sensory response. But then we see a decrement in the amplitude of the motor response because the issue is distal to the ventral horn, but proximal to the dorsal root. So this is a classic example of what you might see in radiculopathy. Preserved sensory responses, so preserved snaps, with reduced CMAPs in the distribution of whichever nerve root is involved. Good. Everybody buying that and everybody understand that, because it's important when you look at your data to recognize why this patient's got numbness and tingling in digits 1, 2, and 3, or 1 and 2, but their superficial radial and their median sensory responses are perfect, but they've got abnormalities when you needle EMG, the tricep and the flexor carpi radialis and the brachioradialis and the other C6 muscles.
I think maybe I get myself confused, and maybe it's because of electrode placement and really how that impulse travels when we stim up through and then coming back, so that it would basically bypass any motor response. We're just getting confirmation that the sensory was intact because it still has to come back, right, to the recording electrode.
I'm not understanding what you mean by coming back.
It's not, it doesn't go all the way through. The sensory doesn't go through the spinal cord, is what you're saying. That's how it can be normal, because we're not recording through the spinal cord.
No, it has to do with where the lesion is. You recognize this?
Yep, there's the anterior and posterior.
Okay. And we recognize this. And we recognize this. So radiculopathies typically are going to, and the dorsal root may actually be more like right down here.
Mm-hmm.
The injury is going to happen here.
Mm-hmm.
It's going to happen proximal to the dorsal root ganglion. It's going to happen distal to the anterior horn.
Yes.
So it's preganglionic. They still have sensory change, but when we stimulate these distal sensory nerves way down in the foot,
Mm-hmm.
they're preserved because there's no Wallerian degeneration. These cell bodies are alive.
So it doesn't go through the spinal cord. It comes. When I say comes back, that the ganglion right there is the turnaround point.
I don't know what you mean by turnaround point. I'm sorry, I'm not tracking what your point is.
I know. I'm
Which
just
goes back. I'm sorry, I'm not understanding what you're saying.
okay.
When we're testing this nerve, person comes in, this patient has weakness in their anterior tib. They have numbness and tingling in the superficial peroneal distribution.
Mm-hmm.
When we stimulate the superficial peroneal nerve distally, we get a normal response, even though they have paresthesias. And the reason we do is because the lesion is happening proximal to the dorsal root ganglion, so the sensory nerves are intact, even though they have paresthesias. Now, what if this person had a spinal cord injury up here? In that circumstance, the motor's going to be normal and the sensory is going to be normal, but the patient can't move their foot and they have complete anesthesia at their foot. But when we test the nerves, they're fine because now the the ventral horn and those lower motor neuron cell bodies are intact, and so are the cell bodies in the dorsal root.
Yep.
Does that make sense?
Yes.
But if the lesion were down here, what do you think the sensory is going to look like?
Everything's going to be gone.
How can the motor be normal if the spinal cord is injured? I didn't understand that. Can you repeat
The
that?
motor nerve conduction distally is going to be normal because the lower motor neurons cell bodies, which lie in the anterior horn, are still alive and intact.
Mm-hmm.
Okay.
In fact, they're hyperexcitable and you may have hyperactive reflexes.
Oh, gotcha.
Okay.
The reason that I'm wanting to go over this again is because this is critical in understanding when you do your nerve conduction study and you're trying to differentiate a peripheral nerve problem from a radiculopathy from a central nerve problem.
Right.
This needs to make sense, and I'll do whatever I can to make sure you understand it. And that's why we want to go over these.
Mm-hmm.
Okay? Does this make sense as to why this is radiculopathy? You guessed it right.
Mm-hmm.
This is a classic radiculopathy presentation. Preserved sensory, low response motor. Okay?
Got it.
Can we move to the next one?
Yep.
What about this? How would you describe this lesion?
Sensory also affected.
Sensory motor axonopathy, maybe peroneal.
Okay, well, definitely peroneal because that's what we're testing.
Right.
So in terms of the peroneal nerve, so you call that axonopathy. Is it complete or is it partial?
Partial on the motor and complete on the sensory.
Okay. I can tell you that with partial axon loss lesions, we will see routinely non-recordable sensory responses, but we'll still see motor involvement.
Okay.
And they'll still have some feeling. So there's not complete anesthesia, but it may feel paresthetic.
Okay.
So, but you're correct. This is a partial axon loss lesion. This, in comparison to the lesion before, the only difference is the preservation of that sensory response that we agreed radiculopathy is preganglionic typically, so sensories are spared, versus partial axon loss injury. Okay? You want the next one? What about this?
Conduction block?
Yep.
Okay.
I would
Anything
say,
else?
I would say partial conduction block with some axonal loss as well.
Okay, partial conduction block with some axonal loss. Anybody else?
Are we saying that that middle segment is normal?
Nope.
Because in terms of
There's normal.
Okay, that's normal. Okay.
So
Well,
what is that? And you'll see this. So somebody said partial or someone said partial axon loss,
Mhm.
and someone said partial conduction block and axon loss. And my question is, are you sure you would say partial conduction block?
Well, I'd say it looks like a complete conduction block at the first set.
Yep.
Yeah, it might be complete conduction block with a partial axonal loss, actually.
Very good. That's exactly how I would write that. Axon loss with complete conduction block.
But you're not identifying necessarily the point of origin with these three.
Well,
because it could be further.
here we are. Where is the point of origin when we see this response? Where is this lesion?
Well, I would say above the knee.
I would say at the knee or across the knee. Yeah.
Across the knee.
But if you went more proximal to that, it should be normal, correct?
You think?
No.
For an axonal loss motor.
But there's complete.
So if I were able to stimulate here, do you think I would see this again?
Well, I guess that would have to do with how far backed up that conduction block is.
Well, where's the conduction block? The conduction block
matter.
is between here and here.
So it's at the knee.
So it's between here and here.
It would still be flat.
What happens if I stimulate here?
You're still going to get a conduction block.
What if I stimulate up here?
Still going to be flat.
Yeah.
Because I'm recording
Down
right
there.
here.
Got it. Okay, so it can't get through, right?
Can't get there.
Got
But
it.
when I stimulate distally, I get this.
Okay.
Yep. And it's
Maximum.
also how you confirm that there is, in fact, a conduction block. So
Correct.
again, what's a requirement for determining conduction block? The ability to stimulate distal to the lesion.
And get a response.
Very good. So this making some sense?
Yeah.
All right.
Yes.
What's that?
Axonal loss.
Axonal loss, yeah.
Partial or complete?
Looks like complete.
Looks complete.
What about that?
Partial.
Oh, no.
Conduction block. Partial conduction block at the knee.
No.
No?
Partial
Oh.
conduction.
Oh, yeah. Okay.
Stem across the knee, there's partial conduction block. Stem distal, stem proximal. Okay. What about this?
Complete conduction block.
Very good.
Can you go back to the partial conduction block slide again one more time?
Mm-hmm.
Okay, thank you.
So here's a case of a patient who Let's just walk through their data. They have suspicious L5 versus peroneal neuropathy. Clarifying examination, okay? Do we see any abnormality in their nerve conduction study of the sensory nerves?
Um,
A little bit on the left, slightly.
left on amplitude is a
Left amplitude of what?
Sensory.
sorry. The superficial peroneal sensory is greater than 50%, but you know.
So you guys would get a red box of death right here, wouldn't you? Because there's a greater than 50% deficit in comparison to the other side.
Exactly.
What about
is that 50% the rule on that one?
Generally. 50% is a good general rule.
The 20% rule has to do with
motor comparisons and conduction blocks over short segments. And frankly, even for motor comparison side to side, 50 is a better estimation. And remember what I said, if you suspect the possibility of axonopathy, what's the rule?
Do an EMG.
That's exactly right. Okay, so in the sensory response, we see that the superficial peroneal sensory response is low in comparison to the other side. Now, assuming when I did my clarifying examination that I suspected either peroneal neuropathy at the knee or I suspected an L5 radiculopathy, is this decrement in amplitude something that I would expect to see in radiculopathy?
No.
I thought,
No.
yes.
Is it something that I would expect to see in peroneal neuropathy at the knee?
Yes.
Yes.
Now, could I see it in radiculopathy?
Yes.
If it was post-ganglionic.
Exactly right. Very good. Okay. So, am I fine at stopping at just doing the sensory nerve conduction?
No.
No.
So maybe I should do some motor nerve conduction. Any problems there?
Looks good. I'm just looking at the waves, but.
Okay, look at the data too. Now, when I look at a data table, the first thing I do is I look here.
The amplitude.
I look latencies, and then I look velocities. Just because that's how I write. And the most important thing to me in motor nerve conduction is preservation of amplitude.
Yeah, looks good.
So tibial motor, if I were to write that, I would say the bilateral tibial motor nerve conduction studies are within normal limits.
Normal limits.
Now, if I were to write this, how might I write this?
The left superficial peroneal sensory is within normal limits. However, there is a greater than 50% amplitude drop side to side.
Good. And
So
then
is
I
it-
might, and
Is
then I
it
might say,
within normal limit? Would you still write that as it's within normal limit?
well, what he's saying is that when he looks at this amplitude in comparison to the normative table, that it's normal
Okay.
compared to norms, but in the comparison side to side, there's a deficit of greater than 50%. And that's an acceptable way to say that.
Okay.
Or you may say that there's a greater than 50% deficit in the left superficial peroneal response with preserved latencies. the bilateral sural sensory nerves are normal. So if I were to say that in 2 sentences, that would be what I would say.
And latency really has to do with the amount of time between when it's stimulated and when you get a response, correct?
That is correct. And in a sensory nerve, that is a peak latency. Okay?
Mm-hmm.
What about this? Is there any problem with this study?
Yeah.
The first thing I need to do is I need to demonstrate and make sure that the way that I test this nerve is of reasonable competency. I feel good about what I do, but the first thing I look at is this.
Yeah. There's a definite partial conduction block there.
So what you're saying is that there's partial conduction block where?
Would it be between the
At the knee?
popliteal and bilateral below fib region?
Yep. So I heard Ganesh say at the knee,
Yes.
and you could also say across the fibular head. That's fine. If we wanted to, someone could divide 1.8 into 4.8, and you could come up with a percentage if you wanted to say that. No, I don't have my calculator handy. Let's see. 1.8.
38%.
Well, 38% is what's left, so it's really 62%. So there's a 62% conduction block of the peroneal nerve across the fibular head. Anything else happening at the fibular head?
Yes.
Decreased velocity compared to...
With a diminished nerve conduction velocity. So there's partial motor conduction block of 62% with slowing in the peroneal motor nerve conduction across the fibular head. Now, short segment testing here identifies that it's happening between the fibular head and 2.5 centimeters proximal to it. That's this. I do this a lot when I see conduction block because I like to walk the stimulator around where I suspect the lesion is to make sure that it's not me. Make sure that I'm not having a technical problem when I'm testing this nerve. And clearly, if I'm at 4.8, 4.8, 1.9, 1.8, and I'm at 50, 18, and it comes back up to 42, this problem is right between this and this.
Right.
Which is between that and that. So I feel good about this being partial motor conduction block at the fibular head. Now, is there anything else that I might suspect? What's this look like in comparison to this?
About a 40% difference or something.
Okay. So some would say if it's greater than 20, it's abnormal. Others would say, well, if it's greater than 50, it's abnormal. Some Bushbacher studies would say, gosh, you may see normal changes up to 60, 70, 80% in some patients that are normal. So what's my obligation?
If the person is symptomatic, then we can we say that decreased or there's a comparative study indicating that there's some abnormality on the left side?
Yeah, that's suspicious. But then if I stick that muscle and it's abnormal, I've confirmed it. And if I stick that muscle and it's normal, well, it may just be a normal variance of normal. But yeah, those are the things I want to look at on that table. I do my H reflexes. Any problems there?
Yep.
Yeah. What problems do I have with my H reflexes? Is there a variance side to side?
You know, it looks good on the table that I can see, but I'm looking at the amplitude.
Okay. You got a good H reflex amplitude norm?
I have no idea. I'm just comparing right to left and what it looks like, but I do not know.
So what would you consider to be an abnormal comparison between H reflex amplitudes?
I don't know. I'm just going off what I see visually and the difference.
So this is the H reflex, right?
Oh, okay. You know what? I was looking at the M wave. Sorry.
Okay. Can't look at this here.
Right.
Yeah, I was looking at the wave too. Okay.
So that's reasonable.
Yeah.
It's a reasonable H reflex comparison. What about the EMG?
Looks like there's some positive sharp waves and fibs.
Where?
Left anterior tib sub EL45. Yeah. Trying to look at your table now.
Mm-hmm.
Okay. So we've got the superficial peroneal and the deep peroneal. So we have different peripheral nerves, but we still have the same L5 nerve root in common.
Anybody want to help? What contributes to both the superficial and the deep peroneal nerve?
Oh, the common. Sorry, common. I should have thought of that.
That's okay. So we have common peroneal or common fibular evidence of denervation. What about anything proximal to that? And this, what's the most important stick in this test here for location? That biceps femoris short head.
That's the one just proximal to
That's
that.
a moneymaker. That's right. It's proximal to the fibular head where we suspect the problem is.
Yeah.
And it's clean. And then we move up and we test some other L5 stuff and it's clean.
Yeah, you're right.
And we test some more L4 and 5 and S1 stuff and it's clean. And we test some non-peroneal innervated L5 and S1 stuff and it's clean. So where is this lesion?
At the knee.
Involving what nerve?
The common peroneal.
Yep.
Mm-hmm.
And what type of lesion is it?
Axonal loss.
Axonal.
And
Demyelinating and I didn't catch the first part.
okay, so in terms of how we presented that information at the very beginning, we see, what does this mean?
Sorry, what does what mean? Sorry.
What is this data telling us here? Now that we've confirmed that there's EMG changes.
The percentage.
Yeah, because below the knee.
The percentage, yeah.
Yes.
60%.
Partial axonal loss below the level of the lesion because you're not absent on that run too. Correct?
Right. There's more happening distal than there is proximal, so that's partial conduction block. But we've confirmed that there's EMG change, so there's also partial axonopathy, isn't there?
Yes.
Right, there's both. Yep.
Okay. So you use the word conduction block more than you use demyelinating?
I tend to use demyelinating in terms of either slowing and or conduction block in reference to what's involved. Is it myelin or is it axons?
Okay.
But yes, I use I use the words conduction block when it's there. And
When you're describing the waveforms.
Yes.
Mhm.
And I don't know. I may have.
More about the anatomy.
Here's how I wrote it. So that's how I described those tables.
Yeah.
I just pulled this from a study that I did, okay? So I don't let the machine generate my report for me. I look at the table, I look at the data, and I tell the story. And that's what you guys need to learn how to do.
Can you go back a few slides before where it showed the a little bit more right there? Yeah, just go where you were just a second ago, I think. Yeah, right there.
Mm-hmm.
'Cause it was on the left side. So would you take the amplitude of the right peroneal motor and the amplitude of the left peroneal motor to determine the percentage of axonal loss?
You could try.
I saw you did it on the conduction block. I was just curious, would that be accurate to do that or not?
You could say, I don't think that it would be accurate to say that that's how many axons are gone.
Oh, that's right, because
it
it's
would
still
be,
within normal range.
But it would be fine to say that that's the percentage difference side to side.
Okay.
And I do that a lot.
Right.
So what is 5.2 divided into 9.1? You said somewhere around 40%, 45%.
I would just kind of guess, yeah.
Yeah. So it's completely fine to say that there's a 40% deficit in the left peroneal CMAP as compared to the right, with frank slowing across the knee and 60% partial conduction block at the knee.
Okay. Thank you.
That can describe that just fine. And short segment testing confirms that this is happening at or just proximal to the fibular head. That's completely fine to say. That's a very good description of that set of data. So that's how I wrote it. I wouldn't ding you up for how you choose to say it, so long as the way that you described it is accurate.
Looks good.
So that's a good point, Mark. So, in the impression, what type of lesion is it? We've all said it. Partial axon loss with partial conduction block of the common peroneal nerve at the fibular head. How severe is it?
Moderate.
Okay. And why would you choose moderate?
Because there was some axonal intact, remaining conduction.
Yep. And the distal sensory responses were still present.
Mm-hmm.
And so I would accept moderate. I would also accept moderate to severe. We've identified where it is.
Mm-hmm.
Now, what's the prognosis in this particular case?
What are our options? Because it's
good.
far away.
It is far from the cell body, but it's not. I mean, it seems like it has a fair amount of axons left, and we know that the partial conduction block is contributing
to the weakness, right?
What's the regrowth rate on those, on the axonal?
About
the
1
regrowth,
millimeter.
the regrowth rate? What's going to be the primary mode of healing in this particular patient?
Collateral sprouting.
Mm-hmm. And
Yeah.
what's the growth rate on collateral sprouts? They first reach their targets within 8 to 12 weeks. Making an assumption that whatever is the cause of this problem is removed.
Exactly.
Okay. And so it's okay to write that. Assuming that whatever's causing this is no longer there, the
Right.
prognosis for recovery is good. It's actually very good.
Mm-hmm.
And was there any evidence of any superimposed processes?
No.
No.
You said very good, but isn't there still there's still some axonal loss that
Sure.
is concerning?
If I go
Okay.
out in the yard and I prune 40% of the branches off the tree, do I expect it to heal?
Yeah.
At what point in pruning might I expect that there's going to be some persistence of problem?
I think I've heard y'all say about 75%.
Yeah, that's sort of a good range, 75, 80%. Once you get above an 80% side-to-side variance or comparison, then the opportunity for healing is not as good. So let's talk about that. How do we, and it's interesting. So, and we talked about this too, I think a couple of weeks ago when we did this. Let's assume we have a tree that has 5 branches. Okay? Or we have an axon that has 5 collateral sprouts. Can anybody tell me how many collateral sprouts a single axon can generate?
I have no idea.
Unlimited, right?
Nope.
Doesn't that have to do with the amount of the dendrites and how big the axon is? Like how the size of the axon anyway? 4 to 5.
4 to 5.
Yeah. I think you wrote it for us.
So if I have 4 to 5 collateral sprouts that can regenerate from a single axon, let's just do some math. If I lose one guy, I've lost 20%. Okay? But this one, this one, this one, and this one can each send up to 4 to 5 sprouts to refill whatever this guy innervated. What's the chance that's going to happen?
Pretty good.
Real good. What if I lose 2?
Still good.
Still really
Still good. What if I lose 3?
I would say it's probably still good, but it's probably getting a little less now.
What if I lose 4?
Not good.
Why?
Because you got no other options. It's all dependent on that
Only
one.
got
And that one can send out how many?
4 to 5 max.
4 to 5 max.
All right. And so I've got to go to these guys and their targets, these guys and their targets, these guys and their targets, and these guys and their targets. So this number is pretty critical.
Mm-hmm.
And it's interesting, isn't it? Now, in the literature, you're going to see that this number is going to vary between about 75 to 90%. And this is real interesting. For continued weakness following axonal injury. Dimitri will say that even up to 90%, you may still see good motor recovery. But 90% is going to exceed this. Okay? My question to you, and I say, well, how can that be? If I only have 1 of 5 left, i.e. 20%, and it can only send 4 or 5 sprouts, anything above that 20% should result in some ongoing weakness afterwards.
Correct.
Okay. How many available motor units do you think it takes for us typically to grade a 5 out of 5 when we muscle test?
Ha ha ha.
Probably what, 75%? I don't know.
Anybody else?
I think it's less than that because I've got people that can do 5 out of 5 and they are not very functional. 50%?
Oh, well.
It's actually about 40 to 50%.
So manual motor muscles, test is
So
kind
for
of
typical manual muscle testing, this is from Basmasian. This is like 70s and earlier data. That you'll grade a muscle test 5 out of 5 most of the time, which is functional. That's good resistance against gravity. With 40 to 50% of available motor units in a muscle, which means that even though you may have up to 90% loss with 4 to 5 sprouts, and you may still get up to 50% of available motor units reinnervated.
Mm-hmm.
And they may grade out pretty strong.
Mm-hmm.
But that's only if they test the manual muscle test in the mid-range. If they take it to inner and outer range, they're going to show diminished strength.
Yes, they may show diminished strength, but that doesn't mean that they can't walk up or down stairs. It doesn't mean that they can't get out of the chair, and
You
it
mean
doesn't mean that
functional.
it doesn't mean that their foot drops resolved.
Okay.
Right, because
Okay.
it's still timing and
Yep.
recruitment and all that kind of stuff.
So from an assessment that we do, from a functional assessment, can they walk? Can they squat? Can they bend? Can they muscle test? Can they do a lot of activities? We may see injuries 90% that still recover pretty good for these reasons. But this 80% is a pretty good number. And interestingly, when you guys get in the literature and you start looking at, well, how much is okay for me to expect that I'm going to get recovery, that 75 to 80% range is a pretty reasonable threshold. And there's tons of literature on side-to-side amplitude comparisons and recovery and injury. What's the best predictor, and we talked about this already, the best predictor of outcome that we have electrodiagnostically is what?
Motor amplitude.
Yep. Remember we said?
CMAP.
Yep. And I think it was you, wasn't it, Mark? We wanted to talk about, is it EMG findings or is it CMAP amplitudes?
Right. CMAP. Yeah, and I thought it was originally EMGs, but
Yep.
yeah.
Yep. So here's why. Is that helpful?
Yes, sir.
Yes.
Good. Because ultimately your patients want to know, right? Am I going to get better or not? And remember that timing is important, isn't it?
Yes.
So you always want to ask those patients, when did this happen? Because you don't want to see that 80% deficit 2 years after their injury and then say, hey, there's 20% left. You're going to improve.
Well, it makes me wonder about, is there a way to induce more collateral sprouting? You know what I mean? I mean, like once it's done, it's done. At a certain point, that's a max amount, but I guess that is the final, right? I mean,
Yeah,
it's kind of like having a kidney removed, you're still only going to have one more kidney.
At about 18 months post-injury, and a denervated muscle fiber is going to atrophy, and it's going to stop eliciting trophic factors to beckon collateral sprouts to reinnervate it, and it'll turn into fibrotic tissue. So 18 months is a pretty important window for recovery.
Dr. McKibben, if you started getting, if they started getting that at about, let's say, 12 to 16 months, you would expect it be at that point axonal regeneration and not sprouting, right? Because sprouting would have happened before.
Collateral sprouting is going to happen first for sure.
Right. So at that point, if you don't notice anything and it's like the 12th month, would you say that that would have to be axonal regeneration? Or would you
If there's more improvement,
right.
probably. We're just guessing, but probably.
Okay. Fair enough.
And I don't know enough of the animal literature that has tracked improvements over years.
That's fine. I was just curious. Thank you.
No, that's a good question, though. Yep. So this is how I wrote that particular study.
So you are doing putting your PT hat on, not just your electrodiagnostician hat, and making some recommendations.
Yeah.
I like it.
I don't always, but yeah, I do a lot. Okay. We're tracking?
Yep.
Good case?
Yes.
Good case.
You should see that case. So radiculopathies. We don't need to go over a lot with respect to radiculopathy, but from a what are we ruling out when we see someone that has myotomal weakness with radicular symptoms, we want to make sure that they don't have peripheral entrapments or plexus problems. We would expect weakness in a myotome, not necessarily a single nerve distribution, with diminished sensation in that distribution, with the diminished muscle stretch reflex in that distribution, if we can do one. And of course, fibs and positive waves and membrane instability in a specific myotome with normal sensory nerve conduction. Now, how often in radiculopathies do we see diminished CMAPs? In the upper extremities, as an example. Let's take cervical radiculopathy.
Yeah.
What motor myotomes do we generally test when we do upper motor nerve conduction?
Median and ulnar.
And so that's a peripheral nerve, but what myotomes are in those muscles? Median's recorded off the APB, ulnar's off the ADM, and those are representative of what cervical levels?
C8T1.
And how many C8T1 radiculopathies do we generally see?
8%.
Yeah.
I don't know. Not a lot.
Yeah. Something down in that range. Low, not as many as the other levels.
C5, C6 is the most common.
Right. Followed by 5, followed by 6, followed by 6, 7, followed by 7, or something like that. So unless we were doing routinely CMAPs off the flexor carpi radialis, or CMAPs off of the triceps, or CMAPs off of a bicep or deltoid, we may not appreciate changes in CMAP like we do in the example that we gave of the L5. But in the lowers, we may see that a lot more. L5S1, we may see reduced amplitudes off the EDB. And L5s, we may see reduced amplitudes off the anterior tib. But we don't see it as much in cervicals. The other reason that we don't see it as much is because of the overlap in myotomes per muscle. Muscles are innervated by multiple cervical levels, and if we have an isolated level, we still have an uninvolved level innervating that muscle, and it may not lend itself to such a significant side-to-side variability in a CMAP if we did even check that muscle with a nerve conduction. Make reasonable sense?
Yes.
Yeah.
So how often do we see ulnar neuropathies at the wrist?
It'd be a fairly rare.
I've seen 3 in my career.
So quite rare.
One was a gunshot wound. One was a painter that closed a can with the heel of his hand, and the other was a bicycle rider.
Okay.
Those are the only three I've been confident that that was the problem. But that's what we might see.
But you know what? You might have saved them from having a surgery at C8T1 level.
Yep. Might have saved them from an ulnar decompression at the elbow.
Yep, because that's where they would have went too.
And I go to my grave and tell that surgeon, it's the elbow. It's the elbow. It's the elbow.
Yeah.
Unless I can do something, and you guys haven't learned this technique. So how might I see this problem and be confident that it's at the wrist if I weren't willing to test distal to the lesion? I'm recording the ulnar nerve off the FDI. I stim at the wrist, and it's a slow, or I don't know if it's a slow latency or not. I don't know how big the hand is. We don't have a good ulnar to FDI motor response, or a motor distal latency that's a good one. But here we clearly see that when I stim the ulnar nerve in the palm recording from the FDI versus stimming the ulnar nerve at the wrist, below and above elbow, there's an 82% conduction block in the transcarpal segment. This response versus this response.
Would you not see that? Because I can't remember. Would you not see that recording off the ADM?
If I were doing a person with carpal tunnel, sure. Yeah, you may see motor conduction block in the transcarpal segment in a person with carpal tunnel too.
Remind me why we're getting the low amplitude above and below the elbow for something that's way down there by the wrist.
You tell me. We just went over it. You asked, in fact, you asked the question when we were talking about the peroneal nerve recording from the tibialis anterior earlier.
I know. Yeah, because...
Where's the problem?
Well, you're telling me on the top of the page it's ulnar neuropathy, but I'm thinking it's someplace else.
Why?
Because higher up, it's not so great either.
Why?
Low amplitude.
Where am I recording?
Because the
that's
problem is distal.
Yeah, I'm not recording above the lesion. I'm stimming above the lesion. I'm still recording from the FDI.
Oh, that's right.
I'm recording below the lesion.
That's right. That's my orientation brain fart. Yes.
It's okay. So in this potential, I'm recording, I'm stimming below the lesion. Here I'm stimming above the lesion. I'm still, and I'm still above.
So conduction block. Can't get
Absolutely.
through. Now, if you compare it above and below elbow, though, it would be fine.
Be the
Right.
same. Yep.
Oh, well, I meant just if you took, what's the name of that one?
Here's the below elbow. Here's the above elbow. Is there a difference? Is there conduction block here?
No.
Nope.
Well, no, not there, but yeah.
So how to
Not one
differentiate
relative to the other. Right.
superimposed problems, if there's any?
Well, in this, I don't have enough data to know
Okay.
Right.
that, so we need to test more. I'm just showing you an example of what you might see in an ulnar neuropathy at the wrist and what you must be willing to do to help to confirm it.
Okay.
Because you guys so far have learned this technique.
Right.
Hadn't even learned that.
Do you have to record off the FDI to do the palm?
Yeah.
Okay.
I don't think that you can do a good palm study and record off the ADM because you're stimming on the belly of the ADM.
I don't know how you would, but I was just double checking. Thank you.
Yeah. The other thing that you can do is you can do a transcarpal sensory study off of D5.
Right.
But sometimes the sensory branch to D5 might be spared if that lesion happens distal to the hook of the hamate and only involves the deep branch of the ulnar nerve.
Mm.
So you may be more apt to try to identify a technique to help you identify it better.
You know, if you didn't do it the way that you did it, you'd have thought, okay, we're looking for axonal loss, and then you've done the EMG. It'd have come out normal on your C8T1s.
Yeah.
Might have had some confusion.
Yeah. You're right. Suprascapular neuropathy. Mimics a 5-6 radiculopathy, mimics rotator cuff tear, right? Night pain, can't raise the arm. Weakness in abduction external rotation without sensory changes. Here's some atrophy. Can we test it with a nerve conduction study?
Yeah.
Yep. Can we test it with an EMG?
Yep.
This is a 2-channel recording in a patient with a, well, let's see. Where's the problem?
At the infraspinatus. Supraspinatus is okay.
Okay. So where's the problem?
At the notch.
At which notch?
What do they call the notch at the end of the spine of the scapula?
Suprascapular notch.
Yeah.
The suprascapular notch
I don't.
or the spinal glenoid notch?
Glenoid notch. Sorry.
I have no idea.
It's at the spinal glenoid notch. So most suprascapular nerve palsies involve the suprascapular notch. And they'll involve both the supra and the infraspinatus.
Okay.
But you can also, this particular patient had a ganglion cyst that was resting in the spinal glenoid notch and compressing the suprascapular nerve. His infraspinatus was shot, but his supraspinatus was fine. Now, here's a question.
Go ahead.
How bad is this?
When was the accident?
Let's just say 2 months. What's the deficit side to side?
Or is that is one purple,
50%?
the other?
50% or?
What's the side to side deficit in the infraspinatus? It tells you on the table if you look close.
96%.
Significant. Because it's flat on the purple, right? I mean, is that the comparison is right to
Yes.
left on that?
Yep. So the problem's on the right when it's slow and it's low.
Yep. And it's how many weeks?
Let's just say it's 2 months. Let's say it's an 8-week-old problem.
That's not good. But the good news is it's close to the. Well, that's a lot though. 96%. That's
Isn't
not
it,
good.
though? Now, is that axon loss or is that conduction block?
Oh, it could be. You're not sure yet. You don't know.
How
You
can
can't
we know?
stimulate proximally, can you?
Well, I am stimulating proximally. I'm shocking at herbs, and I'm recording from the supra and infraspinatus. The problem is that I can't stim distal.
Okay.
So I don't know.
Yeah.
And here's the thing. I don't know whether this is conduction block or not.
So you bring them back in what, 4 or 5 months?
Well, the first thing that happens is we got to get the pressure off the suprascapular nerve.
Okay.
So we got to debride the cysts that are there. This guy's going to surgery.
Okay.
But he wakes up, and I test him 8 weeks later, and he's got completely normal nerve conduction. And no pain other than surgical pain.
No, it's awesome.
And good strength.
Yeah.
What was the problem?
Conduction block.
Okay. But here I don't know, do I?
No. Did he get ultrasounded to find it?
He had an MRI that showed it.
Okay.
But ultrasound could have found it, sure. Pretty neat.
Yeah.
Long thoracic palsies. Mimics 5 and 6 radiculopathies. Mimics rotator cuff tears. scapular winging.
I had one of these with my mentor, my very first. Is
that right?
Stage 1. Yeah.
So here we go. One side compared to the other.
Mm-hmm. That's pretty severe.
Pretty severe, isn't it?
Mm-hmm.
Is he going to get better?
Is that the only that one's long? That's sensory, correct?
No. This
No,
I'm
it's motor.
recording off of the serratus
Oh,
anterior.
serratus. Oh, got it.
Well,
Well,
I
again, you
mean,
don't know.
it's the same question as before, right?
Say
don't
again,
know.
Mark.
Is it the same question as before? We don't know if it's conduction block or axonal loss, correct?
That's correct.
So it's the same thing. We hope.
But why would the EMG be abnormal in serratus?
Well, the EMG said, would the EMG, what if there were partial axonopathy with nearly complete conduction block? Is that patient going to get better?
It should, if you take care of what's going on.
And when you do an EMG in a near complete conduction block, what kind of motor units are you going to see?
Nothing.
Yeah, you're not going to see them. And are you going to see fibs and positive waves in partial axonopathy?
Not that acute.
No, are you going to see fibs and positive waves in partial axonopathy 2 months after their injury?
Maybe 8
Are
weeks.
you going to see fibs and positive waves in partial axonopathy 2 months later?
8 weeks.
Possible.
Now I've heard maybe, and I've heard possible, and I've heard no. Are you, now I haven't heard the right answer yet though. Are you going to see fibs and positive waves in partial axon loss 2 months after injury?
Yes.
Yes, you are. And are you going to see fibs and positive waves in complete axon loss lesions 2 months after injury? Yes, you are.
Mm-hmm.
So how do I know whether this is conduction block or not? I don't.
You retest later.
Yep.
I guess.
What we do, what the last thing, how smart are we going to look if we tell this guy, look, I'm sorry, you're always going to have a winged scapula. This is a horrible lesion. There's a over 90% deficit side to side. And I'm sorry, you're not going to be able to raise your arm over your head, and you're going to have that winging for the rest of your life. And 3 months later, he walks in and says, huh, watch this.
Yeah.
Right.
Okay.
But depending on the cause, I mean, if it's a ganglion cyst, you get it taken care of. You know, I mean, that's
if this was a crutch palsy, if this was brachial amyotrophy,
right.
I'm not sure how much of that inflammation from brachial amyotrophy caused a partial conduction block of the long thoracic nerve, or how much of that crutch palsy that I'm seeing is still residual conduction block.
Mm-hmm.
And
the
I think
point
that's
is, at 2 months, what's important to me is to let him know this is severe.
Yeah.
I don't know how this is going to look. Therefore, a serial study may help us here.
Right. But the fact that he's getting collateral sprouting at all, I mean, are you going to get collateral sprouting no matter what at 8 weeks?
Yeah, collateral sprouts are going to happen.
Okay.
Regardless.
Mm-hmm.
What's a serial study?
What is a serial study?
Yes, sir.
Test, retest.
Okay.
To look for interval changes over time.
How long would you wait to do that again?
2 months.
Okay.
And if in a few months I saw just a little bit of improvement and not significant improvement, I might be leaning more towards axonopathy. And then I might say, I want to see you again 6 months from now. Now we're out there about a year post-injury, and if I still see this, that's not a good sign.
No. Yeah. Okay.
But I mean, in the meantime, do you have any control over that, or it's just like information gathering, data clarity over time? You know?
I mean, yeah, you've got some control if you put them on your schedule and stay in contact with the patient.
No, I meant for intervention. You know, in terms of
Oh, so
looking
what?
at.
So for either of these scenarios, this guy or this guy, what am I thinking intervention wise?
Well, like with this one here, I would at least say get off the crutches if you can.
Yeah,
Get to a walker,
if the
maybe.
crutches were the problem, for sure.
Right. I mean, if
Avoid that.
hypothetically, if he was
Yeah,
being seen for something like that.
certainly work the serratus, right?
Right.
Right.
Maybe use some surface EMG for some biofeedback.
Would
Look
you
Mhm.
at the
do direct
posture.
current with this?
Hmm?
Would you use any DC current?
Probably not.
Okay.
But here's why these things are important, because one train of thought might be, gosh, it's over 90%, it's not coming back. My point in this whole presentation with these is to understand where the lesion is, and based on your nerve study, can you differentiate conduction block from primary axonopathy? And given whether you can or can't, how does that influence the possibilities for their prognosis?
Well, if you can't, then it still leaves it out there that they do have a better prognosis than if you don't write them off that quickly.
Yeah, it leaves it out there that it's questionable, and it's okay to tell the patient that. Look, I
Right.
don't know.
Right.
This could happen, and you could get better, or not. At least it gives them the H word.
Right.
A little bit of hope. Yep.
Yeah. Spinal accessory neuropathy. They going to get better?
Probably.
They got let's just assume it's 2 months. They got a better chance than not. Although
Yeah.
that's a lot of atrophy, isn't it?
Yep.
Radial palsy. Wrist drop.
What's Pin syndrome?
Posterior interosseous nerve. Where's this patient's problem? Now, this is inching proximal to the lateral epicondyle. First of all, what is the superficial radial comparisons? Side to side's right at 50%, isn't it?
Right.
Okay. When I go over and I look at this radial nerve, again, this is a lot like the peroneal study that I showed you earlier. This is how I try and look at them. Typical motor nerve study, I'm going to stem in the forearm, and then I'm going to stem at the spiral groove, and then possibly up in the axilla. And when I stemmed in the forearm, I saw this, and then I went up to the spiral groove, and I saw this, and it was slow. Let's just say it was 38 meters per second. I'm making this up because I didn't show you that data. So I know that I've got slowing between my stem site in the forearm and my stem site at the spiral groove. So what I do is I go above the spiral groove, or above the lateral epicondyle, and I start walking that stimulator along the spiral groove over the radial nerve. And the first one I see at 6 centimeters is strong. The next one I see at 8.5 centimeters is strong. And then I go to 11 centimeters and there's this huge gap in slowing with partial conduction block. See it?
So where were you at there at that point? Or do you know?
I was walking the stimulator over the radial nerve proximal to the lateral epicondyle.
Okay.
So the first waveform is at 6 centimeters above the lateral epicondyle. The next one's at 8.5 centimeters. The reason I'm doing 2.5 centimeter segments is because that's the distance between my stimulator probes, 2.5 centimeters between probes.
Right.
Okay. So I'm just walking it around, just like I'm inching around the elbow in an ulnar nerve. I always do that in a focal lesion, particularly ulnar nerve at the elbow, peroneal nerve at the knee, radial nerve, spiral groove. Because I want to confirm that it's not me. It's not my technique. I'm getting something good distal that's going away proximal.
Yep.
And it's slow. And it's slow right here without question. 50 meters per second, 14 meters per second, 62 meters per second. See that? See the change in linearity?
Yeah, so would that be like a partial convection block there?
Mm-hmm.
Okay.
With slowing.
With slowing? Okay.
Mm-hmm.
Would you call it like it, at the end, would you say with focal demyelination or?
Yeah, sure. Focal demyelination's fine. With slowing and partial conduction block.
Okay.
Can you go back to the previous slide?
This isn't the patient, by the way.
Oh, that's another patient.
Yeah.
Okay.
This was just for a this was just for a talk at CSM. The not all of these are exactly the patient. There's just an example of what you might see in a radial neuropathy, and then some nerve conduction data to go along with it.
Okay.
Posterior interosseous nerve. Don't know based on looking at that picture versus looking at that picture. It's the same picture. I don't know whether it's spiral groove or whether it's posterior interosseous nerve. Anterior interosseous nerve. Everybody understands what the anterior interosseous nerve does. And the reason I'm throwing these up is because these just aren't carpal tunnel, cubital tunnel cases, right? But they're things that we need to be cognizant of. Everybody know how to test for anterior interosseous neuropathy?
Yeah, the little paper test.
The paper test?
No, it's what was it? Is it called Finkelstein's? I'm trying to remember what it's called.
Froments?
Fromans. Thank you. I'm sorry. Geez.
So if Froments is positive, you would see you would suspect that it's anterior interosseous?
Well, they would kind of mimic the picture in the right where they kind of grip it a little bit like more of a circle. They use their tips more.
Anybody have any argument about that?
Maybe I'm wrong.
You are.
Okay.
But that's okay. Froments is to test the ulnar nerve.
Oh, okay.
And you'll use the anterior interosseous nerve if you can't use the adductor pollicis.
Okay.
So the paper test, as you grab it with the paper and you go to pull it away, then you'll flex with the flexor pollicis longus, and it'll look like this on the affected side, whereas it'll be flat on the other side, and you'll squeeze with the adductor pollicis on the unaffected side. But this is the problem. This is the side where the problem is. They can't flex the DIP of digit 2 and the IP of digit 1. So they don't have a good okay. They can't make a good okay. It's flat because the flexor digitorum profundus and the flexor pollicis longus are weak. From a nerve conduction perspective, we can do nerve conduction either using a pin in the pronator quadratus, or we can do surface electrodes over the flexor pollicis longus and stimulate the median nerve at the elbow and compare side to side. Again, if we see an amplitude deficit, we don't know whether it's conduction block or not because we can't stimulate the anterior interosseous nerve distal to the flexor aponeurosis unless we use a needle, and we don't do that technique. But there's an example. Anterior interosseous nerve, unaffected side, anterior interosseous nerve affected side. Slow comparison side to side, 0.7 microvolts versus 11.6, way over 90% deficit. But I don't know if this is conduction block or not. Neuralgia paresthetica, lateral femoral cutaneous neuropathy. No response on the left, great response on the right.
Right.
Deep fibular nerve, foot drop, anterior tibialis, extensor hallucis is weak, numbness and tingling in the web space. There's conduction block of the fibular nerve. Low sensory amplitude wouldn't be deep fibular, would it? It'd be common fibular.
Right.
Tarsal tunnel. Here's an example. No medial lateral plantar responses versus normal lateral plantars, and slow transtarsals. Stimulating distal and proximal in the tarsal tunnel and getting 33 meters per second across the tarsal sinus tarsi. Okay, where are we at? We're at about 9 o'clock. We're doing good. Okay, so did tonight's discussion about conduction block help?
Yes.
Looking at a lesion in order to determine prognosis for distal CMAPs. It's very helpful so long as we can test that nerve distal to the lesion. It's certainly much more uncertain as to prognosis if we're testing across the lesion and we can't test distal. In those instances, we don't know that those amplitude deficits are or aren't related to conduction block.
Examples of such cases where you would be able to get any distal.
Carpal tunnel, cubital tunnel, ulnar neuropathy at the elbow, peroneal neuropathy at the knee.
So all focal lesions only, conduction blocks.
Yes, where in circumstances where it's easy to stem distal to the lesion. Let's look at a case of brachioplexopathy. Here is a patient with you guys tell me where the problem is, and then we'll wrap up on this case. Let's look at first radial sensory. Is this normal or abnormal?
Abnormal.
Abnormal.
All right. So other sensories were normal. Median, ulnar, lateral antebrachial cutaneous responses were normal. Okay?
Okay.
So the only abnormality we saw was in the radial sensory nerve.
Okay.
In the radial motor nerve, we see a low amplitude on the left as compared to the right. In the axillary nerve, we see a severe deficit on the left in comparison to the right. This one is the right, goes up. This one is the left. When we do the EMG, we see fibs and positive waves in the triceps, the EDC, the deltoid, and the lats. You tracking?
Mm-hmm.
Where's the lesion?
Posterior cord.
Absolutely.
Mm-hmm.
Good for you. How bad is it?
Bad.
Moderate.
Somebody said moderate. Somebody said bad. I would say severe.
Mm-hmm.
Now, why would I say severe?
Because of that left axillary motor is pretty well dead.
Yep. And what else? I've got a
It's worse than
definitively
bad.
low amplitude
Mm-hmm.
radial response. Now, here's a good question. This axillary motor,
Mm-hmm.
is that due to axon loss or conduction block in a posterior cord brachial plexopathy?
Well, which one comes off first? The axillary nerve comes off the, I'm just trying to think of which ones, that comes off first before it becomes the radial nerve.
Uh-huh.
So if it's around that area, then that could still preserve distally a better prognosis. But if I'm correct,
is
they're not
this-
going to be abducting the arm.
Here was my question. Is this conduction block or axon loss?
We don't
We
know,
don't
do we?
Why do we not know?
You
Where am I
probably-
stimulating?
I really
You
don't
can't
know. I've never
stimulate
done that.
proximal to it.
I'm stimulating at herbs, so I'm stimulating the upper trunk of the brachial plexus.
Oh, that's right. You're doing herbs point, right?
Yep.
You can't go distal on that one.
Right. I'm not distal. So I don't have a distal comparison. So in this instance, when I write this up, I don't know. This appears that the axillary is much worse than the radial. But I don't know how bad this really is. This was a rucksack palsy. The axillary appears worse than the radial. And it's definitely posterior cord. But I want to do a serial study. So I see him 10 weeks later. "10 weeks later, this was the before, here's the after. Any difference?
Nope.
Not really.
Here's the before, here's the after. Any difference?
Yes.
Yeah.
Yeah.
Okay. This is 10 weeks later. Okay.
Mhm.
Is this improvement due to collateral axon sprouts in 10 weeks or improvement in conduction block?
Well, you won't know unless you do an EMG.
No.
You'll
There's no
know.
way
This
to
is
know.
10 weeks later. I saw this guy at about a week and a half after the accident.
Yeah, we
That's
don't know,
probably-
do we?
Collateral,
we do.
probably? Oh,
Oh,
Say
okay.
again, Ganesh?
collateral, probably?
Nope.
No?
Improved conduction block.
Yep. Look at the axillary change. Oh, get him, Tiger.
Sorry.
It's cool with me. Mine went running out of here earlier. Look at this axillary change on the left. This was it before. This is it 10 weeks later.
That's a significant improvement.
Yeah, both of the. I think that's significant too, no?
Yeah.
I mean, we had the radial went from 2.1 to 4.8. It more than 100% improved. More than 600% improved axillary.
So how would you know if it's, let's say for collateral sprouting? So how would the graph?
When do the first immature collateral sprouts reach their targets?
8 weeks,
8 to 12.
right?
So still got 2 weeks.
This
Yeah,
is
you said when we had the 8-week one, the 2-month one, you said we would definitely see it. So can you have a conduction block resolve with no axonal sprouting?
Yeah,
Because it was never an axonal loss.
correct.
Got it.
There was never any Wallerian degeneration, so there were no, you may have complete conduction block, no EMG changes whatsoever, and the conduction block resolves. If there were collateral sprouts, they don't have anywhere to go because those muscle fibers are fully innervated. You see that in trees all the time. You ever notice how trees have growth behind their terminal leaves, and then you wind up with deadwood on a tree?
Mm-hmm.
You know what deadwood on a tree represents?
Collateral sprouting.
Yep. Never reaches the canopy of the tree because it doesn't need to. It's not allowed to. The canopy's already there.
I get what you're saying.
It just bypasses the route and
Just dies.
just die, right. But the rest of it.
Neurons collaterally sprout all the time. That's always
Yeah.
happening. Just like in a tree. There's always growth behind the terminal branches in trees.
So when you look at prognosis, really the issue is not with the nerves, but it's with the muscles. When you're, I mean, if
I don't
we're,
understand your question at all. Help me understand.
yeah, just in turn, well, to an earlier comment, and we were talking about prognosis with axonal regeneration. At a certain point, the muscle fibers are going to become fibrotic. But up until that point, without that, maybe there's potential.
Yes, there will be potential for healing so long as you've got a muscle that wants to be reinnervated. Yeah.
Mm-hmm.
That potential lasts about 18 months.
That's the 18-month that you're talking about.
Mm-hmm.
So I get what you're saying on some of this, but I'm trying to figure out why again, and I know you said it a moment ago, but I must have missed it. Why did you say it's definitely conduction block versus collateral axon sprouting?
Well, because there hasn't been enough time to, in my opinion, 10 weeks after the injury to see enough collateral sprouting to have caused 100% improvement and a 600% improvement in CMAP.
Okay, good, thanks.
This is a rapid improvement.
Right.
Collateral sprouts, the earliest collateral sprouts they're going to reach their targets are going to be 8 to 12 weeks. And then they're going to mature over the next 6 to 12 months. And this is a 2.5-month-old issue that has already demonstrated over 100% improvement in the radial motor and over a 600 improvement in the axillary motor response.
So if it was collateral axon sprouting, if you saw any change, it would be very, very mild.
Slight changes.
Yeah, and think about it. If in terms of percentages, when we talked about how many branches can sprout, if this were pure axonopathy, how big could this get? Once mature, we wouldn't expect it to be anywhere near a 600% improvement. The most we would get would be between a 400 and a 500% improvement.
Okay. And that would be well on down the road, though.
Yeah, we would go from like, oh, I'm sorry, this isn't a 600%.
600,
This
yeah.
is a 6,000% improvement. This is going from 0.1 to 6.4.
Right. Yeah.
We would expect for collateral sprouts to go from 0.1 to 0.5.
Got it.
Not 0.1 to 6.4. That's a 6,000% improvement.
Got it. That helps.
And we can't have that many collateral sprouts. So that makes sense, yes?
Yes.
Okay. Good. Let's wrap up. Any other questions? So these last ones, is this reinnervation or improved conduction block, do we think?
Improved
conduction block.
Very good. All right. Any other comments? Any other questions?
I have tons of them, but I don't think anybody wants to stay on for them.
Okay.
But I'm curious about lots of things. It keeps me engaged. So
Good.
yeah.
Good. If you're green, you're still growing, but if you're ripe, you're next to rotten.
That's right. That's right. It's taking me back. I feel young again. Let's just say that.
That's great. Good. Okay. I'm going to stop this recording. And I think I'm back with you guys in a month.
Thank you.
Thank you so
Absolutely.
much.
Yeah.
All right.